lupus nephropathy. And you know us medical people, we always like using jargon words. So lupus, you all know what that means. Nephro is a Greek term, and it comes from the word, well, it means kidney, the little powerhouse in the kidney, and I'll show you a couple of pictures so you can have a feel of that. And then pathy, from pathology, means the study of disease. So it's lupus, kidney, disease. So lupus kidney disease. So we're talking about lupus, so if an individual is going to have nephropathy, I'll start using the medical terms now so you're on the same page. If they're going to have nephropathy, that means that they've got systemic lupus. So it's not the lupus that is maybe merely confined to the skin with the rash on the face. Some things to bear in mind. Lupus, we don't really know what causes it. Or we describe it as an auto, as in self, immune disease. So it's one's own immune system targeting one's own body and giving rise to this disease. And when it affects the kidney, it causes inflammation within the kidney. The kidney doesn't function as it should. It starts leaking protein, and if it's not controlled, it can go on to kidney failure. And I don't know if the lights can go down a bit just so we get a better feel for the pictures. So increasingly, nowadays we're talking about something called apoptosis, so it's like a generated cell death. We think that triggers off some of the cells in the immune system, which then presents this self-degenerated tissue to our immune cells, which consists partly of T cells and B cells. And then that stimulates that whole cascade of antibodies. And so you get the deposit of immune complexes within various tissues. And when it affects the kidneys, that's when we get the lupus nephropathy. Sometimes it's good to think of things in numbers. I noticed when you put your hands up, those that have had any diagnosis or any been aware of having kidney disease, it was about 1/3 of you. And indeed, that's the figure that's quoted in the literature. So about 1/3 of individuals are likely to develop kidney disease. I will say, if you were to break people down into different ethnic groups, you'd find that some ethnicities just seem to be more prone. Why? We don't know. Now, kidney disease is complex, and I guess that's why I've spent, how many years is it now, just studying renal medicine. And that's why I work closely with my colleagues, because it's impossible to understand all about kidney disease, understand all about rheumatology, and keep up to date with the literature. So the kidney disease, even though I'm a kidney specialist, I believe it's complex. And there are several types, and the type determines the particular treatment that an individual gets. Another thing about kidney disease, often when it's in the context of lupus, it's often a non-specific presentation. One of the common presentations is a bit of swelling, like maybe swollen feet. Sometimes the hands, sometimes the face. The other thing about lupus nephropathy is one of the complications that we'd rather people didn't have, because it is quite a serious complication, especially if it's not detected on time. Now, the other thing about it is that individuals often have to be on immunosuppressant medications, sometimes for years. If it's not kept under check, unfortunately, people with lupus nephropathy can go on to develop kidney failure. Fortunately, in current times, we've got management for that. So either dialysis or transplantation. Let's just look at the kidneys, you see? These kidneys. We all know where our kidneys are, don't we? I tell you, sometimes when I ask our medical students, they're not sure. But they do know by the time they finish, so rest assured. But the kidneys are at the back. So the kidneys are right at the back, and they're covered in fat. glands, and that's what protects them. Most of us have two, but some have one. And yes, people can get by very well with one kidney, thank you very much. And that's why you have some people being live donors to others that have got kidney failure. Now just imagine we take one of those kidneys and we cut it through the middle. So you can see you've got arteries, you've got veins, and then you've got what we call the ureter, which is where the urine comes out from. And that ureter, it breaks up into lots of little polyps. And if you were to get a microscope, a very powerful one, mind you, you'd find millions and millions of these little tubules. And this is what makes up the nephron, a combination of a little filter and a tubule. They're a very delicate constituent of the kidney. And this is what the actual filter looks like. It's a tuft of blood vessels inside a little capsule. And it's when those little filters go wrong, that's when we start to develop problems such as kidney failure. So these complex little things that are sitting at the back, when they're working okay, we don't even think about them. We think about our heart, think about our eyes, but we don't think about the kidneys. It's only when they go wrong. And then we suddenly realize all the things that they do. Now the kidneys, they're not only responsible for getting rid of excess water and toxins, they're also responsible for regulating bone health because they produce vitamin D. They also help to produce red blood cells because they produce a hormone called erythropoietin. They regulate blood pressure because once again they produce various hormones that help modulate the salt and the fluid balance. And another thing, a very important thing they do, is they regulate the acid-base balance in the body. So don't only think of the kidneys as getting rid of the waste products. They're also important in bone health, producing red blood cells so we don't become anemic, regulating the blood pressure and the acid-base balance.
Have any questions so far? It's a lot to take in, so all happy?
They probably all know all this already, actually. So maybe you'll wonder, so why does lupus cause kidney disease? And who gets it? Well, we've already said it's about 1/3, and you've demonstrated it in this room, about 1/3. It's because of those antibodies. Remember that sequence of events with our immune cells ending up producing antibodies, and those antibodies then sticking within the kidney. And it's not only the kidney, because often at time people that have kidney involvement can have other things like in the nervous system, sometimes in the heart as well as the skin that we can see from the outside. And one of the reasons why the kidneys are so susceptible is because you saw the delicate structure within them. But also at any point in time, the kidneys are receiving about 25% of the blood going through the system. So they demand a lot of blood, and remember these antibodies go around in the blood. It's not 100% possible to predict who gets kidney disease, but for some reason it seems to be more in the ethnic minorities. We don't know why. And the first signs of kidney disease, they might not develop until many years after a person has been diagnosed with kidney disease. Now I'm going to give you a scenario. There's a Ms. X and there's a Ms. Y. And imagine they've both got the same symptoms, which are common symptoms of kidney failure. Remember, they're non-specific. The swelling of the feet, the ankles, maybe the legs, the face, or the hands. Weight gain because of fluid retention, high blood pressure. Maybe the urine looks a bit dark and concentrated. Maybe it's a bit frothy, and that's because of the protein in the urine. The individual might find, oh, I'm waking up at night to go to the toilet. They might find that, oh, I don't seem to be passing quite as much urine as I used to. They might even find that they're getting urine infections, cystitis, more frequently than they used to. Or maybe they never used to do and they suddenly getting it. But let's imagine that happens to two people. One of those people, whose ex, was under the care of your consultant here. Now the issue is that that person is probably going to be diagnosed quite quickly and sent to the nephrology team. Whereas the other person, who maybe was presenting with these symptoms individually and going to the GP, maybe was sent to the blood pressure clinic, maybe was sent to one clinic after another, they might go on for years not being diagnosed. And that's why I'm here today, to let you know some of the symptoms that might occur, because you can share it with other people. Because one of the main reasons why the kidney disease goes on to kidney failure is because it's not been detected early enough. And if I were to take a poll in the room here, I'm sure there are some of you that will say that you went from one doctor to another. It was absolutely years before the doctors diagnosed what was going on with me. Because not everyone has the fortune of meeting up with somebody like a rheumatologist early on. Awareness is becoming increasingly so. So this is just a recap of some of the symptoms. So remember, they're often non-specific, often dark urine, often frothy urine. It looks as if someone's put soap suds in it and then it's just frothing up. Sometimes it can just merely be tiredness, but something's not right. I talked earlier in that pictorial slide about the link between blood pressure and kidney disease. It's mainly because of the hormones, because of the regulation of the salt and the water, and also because of those hormonal changes, the tension in the blood vessels changes. So the heart has to work harder to push the blood through. So the blood pressure goes up. And similarly with the anemia as well. Remember that hormone erythropoietin, that when the kidneys are starting to fail, they don't produce it anymore. And so people can become anemic because the kidneys can't produce erythropoietin, or EPO as we call it for short. The other thing is that when you've got kidney failure, or even when you've got lupus, you might not feel like eating the same way as you normally do. Loss of appetite, tiredness, can't be bothered to cook. And then we have that problem of we become deficient in those essential building blocks for red blood cells, the iron, the folic acid, and the B12. And then also there's the fact that if you've got kidney disease or if you've got inflammation, even from lupus, it affects the bone marrow. And the bone marrow is what produces the red blood cells. And so anemia is very common. It's common in lupus, and it's even more common if you've got kidney disease in association with it. And then the bone disease. One of the main reasons why you get bone disease in kidney disease is because there's a special type of vitamin D that the kidney helps to produce. Yes, vitamin D is produced in the skin, as we all know. That's why we like to get our sunlight. But then if we've got lupus, then we try in a way to avoid the sunlight, isn't it? But it's not all dependent on the skin. The liver's involved, but very importantly, the most potent vitamin D is formed by a change that is undergone within the kidney. So when you're low in vitamin D, you're more prone to bone disease. And also there's some glands in the neck called parathyroid glands. I don't know if there's anybody that has actually got advanced, I don't think there is because I would know you if you were here. But people that have got advanced kidney disease, especially if it's not detected on time, the glands in the neck, which are also involved in bone regulation, can become dysregulated. And so the parathyroid glands, the lack of vitamin D, the poor diet, all contribute to bone disease. Now, there are two types of, yes, Mr. at the back.
What about the glands in the neck?
Yeah.
Is the thyroid one of those?
So the thyroid is a separate gland, and then these are called parathyroid. So parathyroid means beside the thyroid. So they have different functions, but they're in the same region as the thyroid glands.
That's how my diagnosis started with the thyroid and then adrenal glands, they looked at the pituitary gland, and everything, like you say, different doctors, and it's going everywhere.
In fact, that's often the story with lupus, because systemic lupus erythematosus. Yes, a question there.
Does it affect your voice?
Does it specifically affect your voice? Not necessarily, but if you're tired, if you're anemic, you can have changes in your voice.
I have.
Okay. So you can have hoarseness. If you get dehydrated, if you're very dehydrated, you can get hoarseness in your voice. Then just think, there are two types of kidney disease that we broadly talk about. We talk about acute, which happens suddenly. Now the good thing about that is that often it's reversible, and that can happen in the context of medications that we've taken, especially if we've got some underlying kidney disease. And we'll just touch on that briefly at the end. If you've got lupus, if you've got kidney disease, it's important to keep in touch with your doctors, your specialists, because often what we see in the kidney department is kidney disease is as a result of a medication that has been taken. So acute kidney injury, the word acute, can usually be reversed, but not always. Now that's different from the chronic kidney disease that we're often dealing with in the context of lupus. And what we mean when we talk about chronic is that more that is progressive. But does that mean we should give up? No. Because if we detect it on time, we can put in checks and balances to try and slow that progression. So if you think of it, you've got normal kidney function, and we base it on the what we call the glomerular filtration rate, but you don't need to get bogged down with that. But then, just to say that we grade it all the way from stage 1 through to 5, based on how severe it is. Now, if it's just stage 1 and 2, normally you'll still be looked after by your GP. If it's anything from 3 down to 5, then usually you will be known to a nephrologist or a kidney doctor. Now, proteinuria. What is proteinuria? Just as the name says, protein, urea in the urine. So proteinuria is protein in the urine, and that's one of the commonest presentations that people with lupus get. Protein is in all of our bloods, and it's partly, it's a sign of health. You want a good level of protein in your blood. When there's a problem in the kidney, remember those delicate little filters that I showed you, the glomeruli? If they're damaged, they start to leak protein. Now, if the protein is leaking out in the urine, that means there's less protein in the blood. Now, because there's less protein in the blood, what we call the pressure within the vessels, the oncotic pressure, is reduced, and that's why fluid starts to seep out into the loose tissue. And so that's why people get swelling in their feet, their legs, around their eyes. Like some people wake up in the morning and you'll notice that they've got swelling around their eyes. Some people say, oh, I can't fit my wedding ring on anymore, because the hands get swollen. And that's the edema, the swelling, due to proteinuria. And that is a signal of kidney disease. How can we detect it at home? If you pass urine and you find your urine is frothy, that's a sign of proteinuria. And it can easily be checked. It can be checked with just a simple dipstick, which most of the clinics in the hospital do anyway. But also it can be sent to the laboratory for testing. Now we'll just summarize a little bit here. So we've talked about presentation, we've talked about some of the way it's caused. But if you do end up getting to your doctor, whether it's your GP or whether it's a specialist in the hospital, how are they going to make the diagnosis? I'll tell you something. A lot of the diagnosis can be made just from taking a good history. Just from taking a good history. Because often the time that person with lupus is going to have quite a convoluted history. But what we need is we need to add up all those little bits together. Like somebody mentioned, like changes in their voice, tiredness, little things, aches in their joints. Maybe, yes, swelling at times, maybe not always. So it's when you add up all those little things. I seem to get a rash that comes out when it's sunny. It's adding all those little bits together. That's what gives the clue. And often you don't even need to get down to do any of the invasive tests before you know a person has lupus. So it's the examination and it's the history. But then the doctors, when they order the test, they should be tailored, not just ordering random tests. Because remember, everything we do, not only does it have a cost, but it has an implication to the person you're doing it to. But the tests for lupus are things like urine and blood tests to start with, imaging tests, an ultrasound, a scan of the kidneys. How many of you have had a scan of your kidneys? And those of you that haven't, maybe you've had a scan for a baby. It's the same kind of ultrasound scan. And then that kidney biopsy. Now the kidney biopsy, we only do it when it's absolutely necessary because, yes, it is not without risk. But if we're suggesting that it should be done, it's because it really needs to be done. Because remember at the beginning I mentioned that you can have so many different changes to the kidney. And it depends on what you find as to what treatment you give. So the aim is to start those investigations promptly. You don't want a person to end up with kidney disease before you diagnose their lupus, or to be at stage 5 chronic kidney disease. Sometimes what we do is we actually admit a person and get through the investigations very quickly, especially if we think they'll need a renal biopsy, or if they're very poorly. But a lot of the time we can just do it as an outpatient. And so you might find that a lot of blood tests are taken. And one of the special tests we do is for the anti-nuclear antibody, which is almost pathognomic of lupus. In other words, is characteristic of lupus. But what do I, the kidney doctor, do that is a bit different? First of all, there's no patient that crosses our threshold in the kidney department that will not get their urine checked. Now this is how the urine looks when it's frothy. And if some of you reflect, when you go to toilet in the pan, just have a look at it. If it's very frothy, you know that white foam on the top, that could be protein in the urine. And the simplest thing to do is just dipstick it. And then we measure how much protein is in it. If there's just a little, that could be for no reason at all. It could just be, sometimes, for instance, marathon runners, they can get protein in their urine. But if it's more than a certain level, then people need further tests. If it's just a small amount, all we need to do is check it on a yearly basis. And this is just a picture of what it looks like when a person has got swelling on their legs. And one of the ways we know that this is due to what I'm describing is if you press it and then rub your finger along the swelling, you'll notice an indent. Let's just talk about the kidney biopsy. The kidney biopsy, first of all, it will never be done unless it's absolutely necessary. Because remember, there's no procedure that's not without risk. Now, if one has to have the kidney biopsy, is it something to be scared of? I would say no, but then I can say that because I do hundreds, but then I'm not the one having it done to me. What I would say is that most of the time when we do it, it's done in a very regulated fashion. It's like, this lady, for instance, is having a kidney biopsy. You can see she's like, you do have to lie on your front, because remember I mentioned that the kidneys are at the back. In the olden days, it was done blindly. So they didn't have all these fancy machines to actually locate the kidney, etc. But now, it's done looking at the ultrasound scan. The needle that takes the biopsy, it's all done just looking, and so that reduces the complications. And the person who's doing it will explain to you as they go along. And it's actually quite quick. The actual procedure doesn't take more than 15 to 30 minutes. And then what we do is we get this specimen. It looks, in fact, this is magnified. The actual specimen that is taken it's smaller than half a matchstick. So it's just a tiny bit of kidney. And then it's looked at under the microscope in the laboratory by specialists.
Yeah.
Hi, this technique that you just described, is it fairly new? Because I had my last biopsy in February, I think it was 2013, and he just maybe he was very experienced, he just managed to locate them, but there was none of all this screen and imaging at the
Didn't have an
time.
ultrasound scan.
No.
That would be unusual, wouldn't it?
It would be
I had it
unusual.
done in, oh gosh, it's just the ward on the right as you go into St James' Wing.
Okay, sorry.
Who did that? Do you know?
Oh my goodness, it's a lovely one.
Sounds like an
Tall
orthopaedic
guy.
surgeon, maybe.
No, it might be that you didn't realise when he was doing this, because I can't think of any of my colleagues that do.
It's quite possible, but
I mean, not everybody sits down when they do it. So but they always have a scanning machine at least.
It is far safer to have an ultrasound, as you might imagine, because you can actually see where you're putting the probe. And nowadays, I would have thought, Joyce, that there would probably be very few centres that do it blind, if any, in the UK.
I think my first one was in 1992, and I'm sure they would have had one then.
No.
How long
In
has it been?
1992, maybe, yes, well that was when this technique was coming in, the 90s, as it were. So, but now...
How many of you have had a renal biopsy otherwise? What was your experience?
It's the noise that's off-putting, because you're obviously like face down into the pillow, and then you just hear like a hole punch, and it's awful.
Did you have an ultrasound?
I think so.
Yeah,
I had
you
one
mean-
at St Heliers,
Yeah.
but it's just the noise that's the most off-putting bit about it. Everything else is fine, and I didn't think it was particularly uncomfortable. It was just awkward.
Yeah,
And
it
then
is awkward,
but
you
it's
don't
the
mind when you're coming.
noise.
Okay,
And
so
then the lying there, staring at the ceiling for 6 hours. Yeah. Oh.
So the noise that the lady's talking about. See, who's ever played with a toy gun when they were little, or who's got a son who likes playing with a toy gun? So that's what it sounds like. Those toy guns, and actually it's called a biopsy gun. So what it is, it's like you trigger it, you set it, and it makes that noise. So maybe we need to get someone to invent biopsy guns that don't make that loud noise. But what many of us tend to do is before we do the biopsy, which you can imagine just hearing a gun shoot off, not knowing what's going on. What many of us do when we're talking you through the procedure, we'll actually demonstrate it to you that this is it. It's not a real gun. It's just a biopsy gun. So when we get that tiny little piece of kidney, which is smaller than half a matchstick, there are lots of things that there are lots of ways in which it's looked at. It's stained in different ways, looked at through different types of microscopes. But based on that, we get the answer. Now you don't really need to know about all of these, but just like the gradient of the kidney disease, as you get further down the line, that's the poorer the outcome, and the more likely one is need treatment. So if you think of it that the stages 4 to 5 are more likely to need the treatment that we know about, the immunosuppressive treatment. Now as lupus patients, most of you would have had some type of immunosuppressant at some point, but it's just that when it comes to dealing with kidney disease, we have to give sometimes higher doses and to give it for longer. Why do we do that? Well, the reason is that we want to try and stop it from going on to kidney failure. let's just talk a little bit about kidney failure. About the treatment. First of all, it's always good to think about how can I help myself beyond all these immunosuppressants, all these heavy-duty medications that the doctors may want to give me. Can immunosuppressant drugs be used? The answer is yes, they can. Are there side effects of immunosuppressants? As I walked in, I heard people talking about using dark glasses. Now, I'm not sure whether that was in response to a medication or in response to the lupus itself. But there are some medications that can cause eye changes. How long does the immunosuppressant treatment last for? Fortunately, sometimes it can need to go on for years and years, but you won't be on the same high doses. Is it important? Yes, because there's a lot to play for. If we can control the kidney disease, then we don't end up with kidney failure, needing the dialysis and needing the transplant. And that's why if one needs those medications, it's best to just grit and bear it and work with your doctors to see which one suits me. Which one? Because there are lots of different medications now. And then also to remember that although you might have the immunosuppressant drugs or the drugs that are specifically targeted at the lupus, often when it comes to kidney disease, we also need other medication. Because remember the bone disease I talked about, remember the anemia. But there's some just quick lifestyle changes that we can do. And you probably know all these already. One of them, unless you've got very advanced kidney disease, keeping well hydrated at all times is important. So the government's saying drink 5 or 7 glasses of water. Actually, they have got something right. Low sodium diet. I'll tell you something. I've got several patients who, when they were diagnosed with high blood pressure, they said, "Doctor, what can I do?" I said, "Well, exercise, lose weight, reduce the salt in your diet." And I can tell you that a number of them that did that, those measures in themselves were enough to keep their blood pressure under control. Exercise, weight loss, and reducing the salt in the diet. And then maintaining a healthy blood pressure. There's no essence saying, "Oh, I feel like I've got a headache, let me take my blood pressure tablet today." It doesn't work like that. Because what will happen is that the blood pressure end up swinging up and down. So if one's got high blood pressure, you need it to be maintained constantly. I'm sure you all know what one of the major risks of high blood pressure is. Unfortunately, is strokes. And people that have blood pressures that fluctuate up and down are the ones that are more likely to develop a stroke. So the blood pressure tablets need to be taken consistently. Limiting cholesterol, because remember, cholesterol is that substance, yes, it's in all those fried foods, cream cakes as it were, that furs up the blood vessels, but that contributes to hypertension and actually to kidney disease. And then avoid medications that affect the kidneys, especially if one has got kidney disease. Now, non-steroidal anti-inflammatory drugs, some love them, some don't like them at all. In some scenarios, they're necessary, but if you've been diagnosed with kidney disease, it's better to look for alternatives. Well, unfortunately, they do impact the kidney.
Do you all know what we're talking about with non-steroidal anti-inflammatory drugs? What sort of drugs? So yes, correct. So things like ibuprofen, those are available over the counter. And then the prescribed ones like naproxen, diclofenac, any Voltarol. Yeah, any of you take those on a regular basis? So they all can cause problems for the kidneys. So if you've got kidney problems already, they're best avoided.
I'll tell you a little pointer where people get caught out. And unfortunately, some people have actually been prescribed this by medical professionals. They tell their doctor, "Oh doctor, I'm not allowed to have Brufen or Voltarol." And they say, "All right then, why don't you take this cream instead?" And Now, unfortunately, some of those ointments also contain what we call non-steroidal anti-inflammatory drugs. So do make sure you read, and often they abbreviate it and they just say NSAIDs, N-S-A-I-D-S. So it's almost you're looking out for yourself. So avoid ointments that contain that substance.
The absorption actually into the bloodstream through the skin, is it still significant enough to cause an impact on
It can be, especially if you've got kidney disease. So if you're someone who hasn't got any kidney disease, it's different. But if you've got kidney disease, it's more likely to have a negative impact. I don't want to go into the physiology, but I can explain to you outside of this lecture. Now, for those that already have loss of their kidney function, and it depends on the stage. Remember, we went from stage 1 through to 5. For those with the latter stages, I'm afraid often they have to make other restrictions to their diets. And that's why in renal medicine we work very closely with our dietitians, because it's important that people maintain a healthy diet, but then at the same time avoid those substances that cause damage. To be honest, for everyone in this room, whether they've got lupus or nothing, it's good not to have a high salt intake. But specifically for those who've got loss of kidney function, having a low potassium diet, low phosphate diet, and also people need advice on protein intake. There's no use taking a lot of protein because that will put excess pressure. But at the same time, we don't want people to become malnutritioned by not having enough protein. And I know at the beginning I mentioned about drinking enough fluid. Unfortunately, when people get advanced kidney failure, they don't pass much urine. When you don't pass much urine, what happens is the fluid tends to accumulate in the legs, the hands, the face, but also it can accumulate in the lungs as well, and it can put an added pressure to the heart. So sometimes people require fluid restrictions. So lupus nephritis is a serious problem, but most people who are diagnosed on time and receive treatment don't go on to have kidney failure. Now, the treatment of lupus, I purposely put this slide not only because it's one of the most up-to-date steers, and not only because it's in one of the most reputable journals, Nature Nephrology. It's come out quite recently, just 2 years ago. But it breaks down the different ways of treating lupus nephritis. Now, one of the things that's happening increasingly, people are beginning to see that there is some ethnic diversity. And so even from the onset, when it comes to lupus nephritis, we all know that term now, inflammation in the kidney, or lupus nephropathy, or lupus with kidney disease, people are looking at, should we do something different for, say, black or Hispanic? You know, this is American, so often they use that term for like the Spanish people, etc. But it would also, and something different to what we do with the white and Asian people. You'll find that in different centres, and I believe some of you have come from different centres other than St George's, you might find that if you speak to contemporaries, you might find that they're on a different treatment, even though they've got the same disease process. But commonly nowadays, as a starter, even in the presence of kidney disease, we often use steroids, yes, and mycophenolate. How many of you are on mycophenolate here? And the brother, or the older brother, because it was around long before mycophenolate came, was azathioprine. Is there anybody on azathioprine here? Okay, so fewer people. Okay. So, and for those that it works for, it's pretty good. And for people who respond well, they'll just stay on their low-dose steroids, although many of you will know, some of you would have even had the steroids as an injection, methylprednisolone at some point, and then been on high-dose oral prednisolone, which is then tailored down. But then, like I said at the beginning, sometimes you're on the lupus treatment for years. So the low dose, but it's low dose because remember, all these things do have side effects if they're not monitored. And that's why, if we've got a chronic disease, we do need to keep coming to clinics. It's for the monitoring. So low dose steroids and mycophenolate or azathioprine, that's a relatively common combination. Sometimes we have to use high dose steroids, high dose mycophenolate. And sometimes that's not enough. Who's heard of something called cyclophosphamide? Has anybody actually had it? No. Okay, no.
Rituximab instead. They were deciding between rituximab and that one.
Okay. So I would say that if it had been 10 years ago, they wouldn't have been deciding between rituximab and cyclophosphamide. It would have been straight to cyclophosphamide, especially if someone wasn't responding very well at the beginning. So rituximab, for those that haven't heard about it, it's a new treatment which is directed directly against B cells, some of the antibodies on the surface of the B cells. So by using that agent, we believe that maybe it will be more effective, but also that it may have fewer side effects because it's targeted specifically. And in fact, there's a trial that's beginning to evolve. Do you know about the rituximab?
Yeah.
There's a trial that's beginning to evolve that's trying to look at using rituximab and maybe less of steroids. But it's early days yet. And so, cyclophosphamide, rituximab, the mycophenolate. I mean, maybe what I want you to take away from this slide is that how we decide will depend on the kidney biopsy when it comes to the lupus nephritis. It will also depend on the response of the individual. And it will also depend on the general severity of the disease. And remember, when an individual has got kidney disease, they may have other systems involved. And so when I'm managing lupus patients, I don't just do it in my own little corner. I'm constantly talking to my colleagues. And it's the same vice versa. Remember I mentioned that it's not only the immunosuppressant medications. We have to use medications beyond the immunosuppressants. Medications that control blood pressure. Medications that dispel the water retention. But also there are the side effects. Can anybody shout out any side effects that they've had from immunosuppressants?
Increased infection.
Infections, yes. And so from the onset, what we sometimes do, especially when people are on the high doses, we give them not only antibacterials, one called cotrimoxazole to prevent chest infections. Sometimes we have to use antifungal agents, antiviral agents. So there'll be other medications to prevent the infections. But also to protect the bone. Sometimes we have to give vitamin D and calcium. But also, when we're using some of these medications for the women, and actually for the men to a degree as well, they can affect fertility. And so we do have to use contraception. And then, remember, lupus is a systemic disease, so some people, it can affect their ovaries. And so, while they've got that flare, sometimes they have to go on hormone replacement, and then treating the anemia. Remember, the kidneys produce the erythropoietin, so sometimes we have to replace that, but also replace things like the folic acid and the iron. So people are often on many medications. Now I'm just going to end here. I'm hoping that increasingly we'll see fewer people that end up reaching what we call end stage or kidney failure that can't be reversed. Fortunately, unlike say 30 years ago, there are things that we can do. If people have got kidney disease that hasn't responded to treatment or isn't reversible, we tend to do one of these three things. And I'll just show you some pictures just so that you've seen all of what I do in the kidney department. So a common one is hemodialysis. What does it mean for someone to go on hemodialysis? It's not easy. It can be life-changing. Fortunately, it's nothing like what it was, say, in the 60s or the 50s when they first started doing it. But still, it is life-changing because individuals have to go on a machine 3 times a week, and they're on the machine for 4 hours at a time. And what that machine is doing is it's removing toxins, removing excess fluid. But if someone goes on a machine for 4 hours 3 times a week, that's 12 hours. So they're having kidney function for 12 hours, unlike what we have 24/7. So it's not ideal. And that's how we do the dialysis. We do it through something called a fistula in the arm. Or sometimes, as a short-term measure, we put a cannula in the neck. But the danger with the cannula in the neck, using that for a long time, it can lead to infection. So we always try to use the fistula as soon as possible.
Has anybody had hemodialysis here?
Okay. What did you use when you were on hemodialysis?
I just had the one in the neck,
Okay.
and then now I went to peritoneal.
Okay, and then you went to peritoneal.
So I'm on peritoneal now.
Okay, okay. Has anybody had hemodialysis for a short period and then come off of it? Or any dialysis and then come off of it? Sometimes that does happen. It's not common, because by the time you have to go on to dialysis, usually you've got to the stage 5 of the kidney disease.
But I suppose transplant recipients would have it temporarily before the transplant becomes available. Anybody here with a transplant at all today? Okay. But life-changing, I think, as Joyce said. What's your peritoneal dialysis been like?
Yeah, it's been a lot better than the hemo. Hemo was, it's very stressful. Well, it's quite an intense process on your body. Like you say, it's 4 hours, 3 times a week, and your blood pressure rises and goes down, and it's quite it's literally cleaning your blood and putting it back in
So
again.
it's
It's like,
precisely the sort of stage we just don't want to get to in lupus.
exactly. No.
And did you feel very tired after your session?
Yeah, afterwards I
Washed
couldn't
out.
do anything. I was also washed out. I'd get really bad headaches, migraines. I just had to go home, and I just felt so weak. And it was really, I think I was particularly bad. Though some people were, had got a bit used to it because this all happened to me this year. It started all in February. So.
Okay, so that's one thing. So I will say there are some people who don't have the choice of a transplant, and so that's what they have. When you first started, it can be difficult getting used to it, but fortunately the machines are much more modern than what they used to be, and so there are ways that we can fine-tune things just to make it more comfortable for people, and also the system gets used to it. But the peritoneal dialysis, so that's another way of doing it, and our lady mentioned that that's what she's using now. Well, there are 2 types. I don't know which one. So one is called continuous ambulatory peritoneal dialysis, and that's because you do it throughout the day. So you change the bags manually. So it's like this. There's a tube in the tummy, fluid drains in, it's left for a period, and then you drain it out. And that fluid, it actually takes off excess fluid. It's very clever the way it works. And it also takes out toxins as well. But the thing about this is that you have to do it manually. Like you can imagine hanging off a bag, doing this. But this lady is handling it very well. She's getting on with her life. She's reading a book. But that's one type. But there's another type where you attach to a machine overnight. So you don't do all the stuff during the day, but at night you're attached to a machine. Now, because you'll be on that machine, sometimes it's as long as 8, 9, 10 hours even, depending on how the clearance is for you. It's not always easy because, like, if you're with your partner, you're on a machine, it can be difficult. But there's some ways of working around it, like some people sort of like do varied hours, etc. But you do have to be consistent with it because it's not as powerful as hemodialysis. So while hemodialysis is done 3 days a week, this has to be done every day. And that's the machine. machine, and I can tell you, this machine only came about 15 years ago. Before, everybody had to do this, so it wasn't easy.
The machine noisy.
I'll put it like this. It is when you first start, but then it becomes background noise. But then actually, why don't we ask someone that's doing it? What do you think?
Yeah, at first it sounds like little clicky crabs. And the first couple of nights, my boyfriend was just like, no. At first.
Okay.
But now he sleeps through it all. The only thing, now it's fine. It's like background noise, like you say. But then sometimes it alarms.
Okay, yeah.
So it's the alarms and
Yeah,
that. He
yeah.
sleeps through it all now, but obviously I can't. I have to get up.
So how many times a night do you wake up?
Well, most of the time it's fine, but every now and again it might beat 2 or 3 times if it's not draining properly. So.
Yeah, so that's the issue. But if it's draining okay,
It's fine.
okay,
Yeah,
it's fine. It doesn't
sleep
make
through
any
it.
noise.
Yeah.
Except that background noise. It's like the fridge. Okay, how many people can sleep with the fridge on? You can't sleep with the fridge on. Okay. So, but it's that kind of noise, that background humming in the background. That's how it is. But when it alarms, that can be not so good. But the good thing about it is that there's a lot of support for these kind of dialysis in that you have people at the end of the phone that you can call. The company are quite responsive. And there's something about Renal. Do you have a dialysis team that look after you? Do you?
Yeah, I'm at King's.
At King's, okay.
Yeah.
Okay.
So
it's kind of,
yeah, but the company who do the machines are also there for any problem as well.
but I'm hoping that most people in this room will not get to this point because we'll diagnose it early, manage it quickly. But then even the people that have got to that point of dialysis, kidney failure, dialysis, does it have to end there? No, it doesn't. Because actually, since the 1950s, people have transplants, and in this hospital we do over 150 a year. And there are 2 sources of kidney transplants. One, it can be from a living donor. On the other hand, it can be from people who, they just bequeath their organs and say, well, when I die, I'd like to do good for mankind. And that's how we get most of our kidneys. From people who just say, when I die, use my organs for others. Now the thing about the transplant is that not everybody can have it, unfortunately, because it is an operation which takes at least 2 hours. So to have that operation, you have to be reasonably fit in the first instance. And I'll just let you into some little secrets that I always catch medical students out. I ask them, where do you put the kidney? And a lot of them say, oh, where my old one was. But the answer is no. The transplant kidney is actually popped just here. Just in the lower part of the abdomen. So kidney transplantation, if we do have end-stage renal failure, ideally that's where we want to be. Is there any disadvantage of kidney transplantation? I'm afraid yes, there is. In that if you have a kidney transplant, you do have to take anti-rejection medications for as long as you want that kidney to last. What anti-rejection medications? Is anybody asking that?
Would it be cyclosporin or something like that?
So increasingly many centres are using tacrolimus. But I'll tell you a little secret again. You're already familiar with the medications we use, steroids and mycophenolate, and maybe azathioprine. The only new one for some of you, and actually some people with lupus already use tacrolimus. So actually it's similar to what many of you take already. If I've got kidney disease, can I be sure I'm getting the right care? I think in the UK you can. Because if you've got stage kidney disease from level 3 to 5, you will be in a kidney unit. You should be known to a nephrologist. You should be known to a nephrologist. And one of the reasons why it's good to be known to a nephrologist early is because that way things can be planned. That way measures can be put in place to try and prevent the kidney disease progressing. And if it does progress, if it's dialysis, you can actually work together with the team to choose. Did you choose which dialysis you wanted to?
Well, at first it was emergency, so at first they put the line in just as an emergency thing, and then they asked what I wanted to do. Because they thought the kidneys might come back, but then when they realised I was going to have a transplant, they were like, oh, do you want to go to peritoneal?
Yes.
Because you have more free time.
Yes, you do have more free time. So, you know, it makes a big difference if you can work with a team. And in the renal department, it's not just the doctors like myself. Actually, it's a whole team of dietitians, kidney doctors, nurses, and a lot of specialist nurses. You have specialist nurses in peritoneal dialysis, another specialist set in transplantation, another specialist set in hemodialysis. So you find that you're working with a team. Another thing that I like about our specialties, actually, rheumatology and nephrology, is that they're very, very, very keen on research. And so often a time you might find that you're invited to participate in trials, because we do take notice of the outcome of research that is done properly. And that's why you're finding, like the rituximab, that wasn't around to use, say, 10 years ago. It's because of research. So things keep evolving. So treatment is staged, it's planned, and it's worked through as a team. I'm going to end here, actually. I'm going to end here. But there are some things that I just want to say. And maybe the main thing is that if you have got kidney disease, yes, it is the more serious spectrum of having lupus, but it's not the end of the world. It's not the end of the world at all, because we're not in the early 1900s. There's so much that can be done. There's so much that is in place to support you. And so maintaining quality of life is key. It is a long-term condition. You will be on medications. You will need some sort of support. But that doesn't mean that you can't have your life. People on dialysis, whether it's hemodialysis, peritoneal dialysis, they still go off and have holidays. With a transplant, you can certainly go on holidays. The only thing is that you need to take the medications. Can I still have a family? That's one of the biggest questions, that whether the kidney disease is due to lupus or other things, that's one of the biggest questions that women ask. And the answer is a resounding yes. Don't you have many patients who've had babies?
Yeah.
And so
absolutely.
do I. Even patients who've had kidney transplants, they have their babies, thank you very much. The only thing is that we need to work together with specialists and see people through that process. So why don't we stop there? And if there are more questions, then I'm happy to answer.
Thank you very much. Yes. Let's just put the lights on. So, does anybody have any questions about what is really a very, very important part of lupus management? Yes, sir.
You say about the going through your history, because I haven't actually been diagnosed, but I think it's going to be diagnosed. How do you get a doctor to look through your history? Because I've asked them about it, and they keep like shying away from it, if you like.
How do you get what, sir?
Look at the history, my history.
How do you get diagnosed, you mean?
Yeah, basically you said like a lot of it is looking through your medical history, and like all the symptoms you've had over years.
Yes.
I've mentioned this to my doctor. They're very reluctant to look at my history. I've even said to them, can I sit in a room with it? And they say like, oh, you won't understand all the writing because doctors are writing all this. So how do we get the doctor to actually start looking through my history, looking for key points?
So one of the things I've noticed actually is that in a way the patient has a lot of the power. One of the things, if like yourself, if you've got a very complex history, to be honest, nobody knows that history better than you. One of the ways of doing it is actually making notes by yourself. Sort of like, what has happened? When did my symptoms first start? What were those symptoms? and actually presenting them to the doctor. Because one thing you find nowadays, be it in GP practices or be it in hospital, you might see one doctor today and then another doctor the next day. But you're the constant in all that. So potentially, if you can get a summary of all those things that have been happening to you, all those symptoms you've had when you had them, and the next doctor you see, present them to them, and you might find it will almost be like a light bulb switching on.
I did that, and that's why they said we look like it's lupus.
Well, who have you actually seen though?
Basically, it's the thyroids and the adrenal glands. I thought it was all to do with that.
But have you seen a rheumatologist?
No, not yet.
No. So part of the problem is if you're seeing GPs, they will not see much in the way of lupus, and they might test for it. And interestingly, I've just written an article for GPs on this particular area, which will appear in the GP magazine, but they won't see much of it. And I think it's important to remember you've got to see the right person in the right place. And even some rheumatologists may not be that familiar, won't see a huge amount of it, may not have an interest in it. So it really is about seeing the right person at the right time. And if you're worried about something, then you should go to your GP and say, listen, if you don't know, please refer me. Okay, this is somebody who does.
Have you been referred?
No, not yet. No, I've only had blood tests on the 28th, so there's still blood tests. It's all the little things like mouth ulcers, the puffy eyes, joint pain. I keep saying it's tennis elbow and everything. It's going on and on and on.
Okay.
But yeah, so I think I'm going to talk to my doctor and say maybe you need to refer me
Actually,
to.
I will say this though, and probably agree with you. Even if they do the lupus test and they're negative, it's worth still asking to be referred.
Yeah.
Because sometimes the tests don't become positive at first.
Well, it was only probably a few weeks ago when I said to my doctor, you've done a urine test. And so she said, oh yeah, we better do one of those. So it's...
Yeah, as I say, the level of familiarity from GPs isn't that high. And, you know, I think if you're concerned about something and you've read on the internet actually that fits these kind of symptoms, I think it's perfectly reasonable to say to the GP, listen, I'm not getting anywhere, can you please refer me to usually a rheumatologist, because maybe a renal doctor depending on what the urine test shows. But in rheumatology, we should be getting these kind of referrals. Which area do you live in?
I live in Morden, up in Wimbledon, so this is my hospital.
Yeah. So you should just be referred really, and we'll see you in our lupus service. It's a pretty comprehensive service now, and we'll be happy to say yay or nay really to all of that.
Again, the last thing she done was I had to sit with a neuro specialist. Brain fogs and the headaches.
Yes, yeah.
So they just send me to all.
It's a very common symptom. A brain fog. It's a very common symptom generally, but it's associated with things like fatigue and tiredness, and it's sometimes difficult to pin down why it happens. In fact, it's difficult to pin down why it happens. Period. Okay. It seems to happen in a lot of lupus patients. You right person, right time. Okay, that's really what you need to get in your mind, when you see your GP, because they have a level of expertise. Remember, GPs see 80% of all NHS patients, so they are overworked. They may not have the necessary skills, and they understand that for these particular issues, or to deduce what might be going on. And even in the world of rheumatology, it sometimes can be difficult. And we've got a lady here who says, somebody told me I've got lupus, then somebody says no. And these kind of issues with lupus are not uncommon. We like to think in absolutes, but actually the real world, the immune system doesn't work that way. Okay, and you can be in a grey area where you've got some features of these conditions, but not 100% of them. And that is really where GPs may stumble a little bit. It's easy when it's all obvious, and the blood tests are all obvious.
Well, I'm seeing her on Tuesday, so if I say to her, can you refer me to...
You should do, and I would encourage you, any of you that are not getting anywhere with your GPs, just to say, please refer me. Okay, and a lot of patients will go in anxious, thinking I don't want to cheese my GP off. But
So
you
you
know,
would just say that you came through
But
a
you shouldn't,
meeting
you
and they
shouldn't.
advised you
Yeah.
to see them.
So I've been off work for 9 months now. I want to get back.
yeah.
So there's a question
Yeah.
here.
Yeah, I
And
just
then-
wanted to ask,
So
why
I
there
work
seems
for
to be
London
so
Ambulance as
much
well, so I just wanted to
inconsistency among
I know it's
rheumatologists.
something, and they got the back of
On
and
the
started doing
Lupus
tests on
UK
me.
forum,
That's
they,
how it started.
so many people see rheumatologists that dismiss it instantly if there's nothing in the blood, and others like that see beyond that and they know it doesn't always show immediately, it takes some time, there's putting all the symptoms together. It just seems that rheumatologists, there's always no consistency amongst the different rheumatologists.
I'm glad,
It's like, yeah.
I'm glad your question is on rheumatologists. Hand that question, but I'll quickly add a little thing. Dr. Kaul, you're lucky to have him here, but you know, he's a specialist in this area. So just like kidney medicine, as it opens up, like my specialist areas are immune system, transplantation. I've got another colleague who's a specialist in hemodialysis, another who's a specialist in peritoneal dialysis. It's getting so broad. I'm going to hand that question to Dr.
And the answer is that, again, not all rheumatologists will have a special interest or will know about the nuances of what we see with patients who have lupus or immune-mediated conditions which are part of the way down towards lupus. And that those grey area symptoms are what people will often, or rheumatologists will often dismiss as well. It's not lupus. And the issue about the blood tests, the anti-nuclear antibodies, one of the key issues. And I can tell you I've seen patients with negative anti-nuclear antibody tests whose renal biopsy shows clear active lupus nephritis. Okay, so one has to be careful about dismissing these kind of cases. It is now reported in the literature, there have been case reports of negative anti-nuclear antibody testing, but actually biopsies are strongly positive. So one has to think in these areas of shades of grey rather than in absolutes. Now, I can't, for the life of me, educate all rheumatologists to think that way. That's the way I think, but unfortunately you'll find other doctors who don't think that way, who will just say it's fibromyalgia or it's some other chronic pain or something like that. That's life, unfortunately, and we have to deal with shades of grey in rheumatology as well, and different opinions. It's not my opinion, so that's all I can say.
When you're trying to get a referral, I mean, luckily I have you. Like when you're trying to get a referral, how would you know who's a good rheumatologist?
Well, it's probably, I mean, you've got a lot of, it's a different era now from 10, 15 years ago. You've got the forums, you've got Lupus UK, you've got so many avenues where you can, just sound out, other people, other patients, who do you think's good in this particular area, my area, or anywhere else. And if you feel you need to go outside your area, my advice is don't be frightened, okay? Remember, at the end of the day, the GP should not be controlling your destiny. You should be controlling your destiny. And if you want to go somewhere, tell your GP. If your GP gets, you're telling me what to do, well, you've got your middle finger. Okay? So you should be controlling where you go. Okay? So it's difficult for me to advise you on that because people have bad experiences everywhere, but most people actually are quite happy with their rheumatologist, I suspect. But ask around in the forums, ask in the Lupus UK websites, or friends or family, what do you think of this person? That's probably the best recommendation, really, I think. And coming to meetings like this, you'll meet other people who will also give you recommendations.
Another thing, all the men in the room, raise your hands. All the men in the room with lupus. Can you see something? Can you see something? So they talk about 1 in 9. So unfortunately, for a GP, they're not going to think of lupus when they see you, first of all. But there was another question here.
I wanted to know the progression of a minimal change lupus nephritis to membranous. Is that the next step, or does it not work that way?
No, it doesn't. In fact, I don't want to think back through loads of slides, but remember with that lupus, we had normal kidney, and then we had stage 1 through to 5. So the membranous ones are actually the stage 4 and 5. Okay. But something about lupus, it's a very strange disease. That's why we just don't understand it. might be someone who presents with one form. So it's not necessarily that they're actually progressive. They're just different presentations of a different immune process. So someone might actually present with, say, stage 4 on one biopsy, then more of the changes of stage 3 on another biopsy, and then at one point might present with stage 5, which is the reason why some people have had to have more than one. How many of you had to have 2 or more biopsies? Okay, so that's why. It's not just that they want some target practice, but it's because they're trying to see, has the disease process changed? Should we be treating it in a different way? So like the rituximab, that is a targeted treatment is more targeted nowadays. Well, that lady had a question in the pre-talk.
That's right. I just wanted to ask, when they do a biopsy on one kidney, can they also know about the other kidney?
That's a very good question. Now, for some disease processes, I would say not really. But you know that lupus, if we call it by its full name, it says systemic lupus erythematosus. So nothing is 100% in medicine, but because it's a systemic disease, it's probably going to affect both kidneys.
So the reason I ask is
Yes.
when they was doing my biopsy, the kidney they told me they were going to look at was not the kidney I was feeling something's going on with.
Okay.
I just made the assumption,
That they do the
Yeah.
kidney back.
but having said that I am still having that problem, but the kidney they tested was fine. That's why I asked the question.
No, it's a good question actually. But remember, and I put it just at the corner on the other side, so lupus, systemic lupus things are usually on both kidneys. But it may not be lupus, it could be something completely different. The fact that one has got lupus doesn't mean that one can't have another condition. And there are some particular things that are more common in people that have got lupus, which could happen in anyone else, such as interstitial nephritis, which is inflammation, such as infections, partly because of medications. But there are some other pathologies as well. For instance, there could be kidney stones, which is something that commonly causes pain, and they might just be tiny, that they might not be able to detect them on the scan. There are a whole host of other things. In fact, causes of kidney diseases, it goes from there down to the ground, as it were. So it could be something else. And that's why we don't only do the ultrasound scan, but there are some other types of scans that can be done. The other thing about kidney biopsies, you saw how tiny that, the kidney is about 10 centimeters, so it's about that big. But you can see we only take a little sliver of kidney. So although I say it's a systemic condition, it doesn't mean that every single part of the kidney is affected in the same way. So that's why often we like to take 2 pieces of kidney when we're making a diagnosis. So there could be sampling, it could be another pathology completely. There's so many things it could be.
When you're doing the biopsy, how do you choose which kidney?
Well, there's some conventions. So it's kind of, you want to do what is safest. So first of all, you're not going to do a biopsy in someone whose kidneys don't look like they'd be safe to biopsy. When people's kidney diseases progress, the kidneys start to shrivel up. In those scenarios, we don't like doing biopsies because they're very likely to bleed. And then looking at the kidneys, it's like, if there's an obvious abnormality in the kidney, you'd even think, well, actually, maybe I shouldn't be biopsying these kidneys. Maybe there are other ways that we should be looking at things. Most of us would, well, I wouldn't say most of us, most people look up the other organs because, you know, on the right side, you've also got the liver, and on the left side, you've got the spleen. Now, everybody's anatomy is different. Now, with some people, their spleen is a bit bigger than others. So you choose by choosing the safer size to biopsy as it were. Does that make sense?
Mine is asymmetrical, so one's much bigger than the other.
Okay.
So I'm not sure which one they took the biopsy, because would that be to take it from the larger one?
Well,
Or not
actually,
necessarily?
many people would have been debating long and hard, should we take a biopsy at all if they saw that the kidneys were asymmetrical. But then, some people have asymmetrical kidneys naturally for no reason at all. It might be like, has anybody ever seen somebody with 6 fingers before?
Yes.
Yes. So likewise, you can get similar changes in the kidney as well. So sometimes naturally one is bigger. It's difficult to say. It's difficult to say without seeing the kidneys and seeing the structure of them
I
as to
think they
which one
said
they
when
take.
they checked that they were both functioning evenly, even though one was bigger than the other.
And that happens sometimes because some people, like, they've got 2 arteries, 2 blood vessels that supply, so one ends up a bit bigger, the other smaller.
Why is it I have to be doing the monthly blood test?
Why is it they
I have to be doing the monthly blood test because
monthly blood tests?
Yes,
Lucky
I
you,
have.
there's someone that cares about you. Why? Remember, that was one of the things I pointed out. In fact, it is sympathy because it is quite a few blood tests. But the things that they're monitoring, probably they're monitoring their kidney function. They're monitoring the kidney function. They're probably, if you're on medications, they're monitoring the effect of those medications for any side effects, as it were. They're monitoring for response as well. Remember I mentioned that the kidneys don't only excrete the toxin, they do other things. They might even be looking for things like anemia, whether you've got enough of the nutrients that you need, like basics like iron, folic acid. There could be so many things, but it's clear that they're keeping a careful check on
yes,
things.
my doctor told me that yesterday about the anemia and all that.
Oh, well,
Yes,
there you-
because I went to my dietitian and
Okay.
my urine.
Yes.
She said she saw something like some blood in it.
Okay.
Anyway, I didn't understand it away. Yesterday I go and see my GP and she said everything is fine, my blood test now is fine, everything is fine. My kidney is fine and everything. But I have to come here every month to do blood tests pertaining to the medication I'm taking. So
Because of the medication you're taking. Okay, so that's
yes,
explained.
because there's 3 medication like the steroid because they put me on 1.0 now. And there's other 2 I can't pronounce the name. I see you put 1 there.
Okay.
Yeah, 3.
Okay.
So I'm on those medication, 1 a day.
Okay.
The steroid is 1.0, but it's 2 small tablets I'm taking with my metformin.
Okay, so there's a lot to monitor there. So,
Yeah.
and liver function test might be another thing because some of the medications do affect the liver. So there's a lot to monitor. But one thing though is that I know it's difficult sometimes, but sometimes it's good to talk to your doctors and say, "Oh, could you explain what these blood tests are for?" It's not.
I know the blood test here is here. I come monthly
Okay.
to do that blood test.
Okay, so when you see the doctor next, ask them, "Oh, could you explain what the tests are for? Or could you explain the results to me?"
Yeah, okay.
So,
And we had a session on explaining blood tests. We had a session a few months ago on what the blood tests mean, and we can repeat that again. So it's not a problem, and we can explain why do you do the blood tests, how frequently, etc. So, and in the second bit of this session, we can also answer some of that. Any of the other any kidney-related questions specific? Because we'll have to let Joyce have the rest of her Saturday.
You said about people can donate a kidney.
yes.
And then when you do a transplant, you obviously only replace 1 kidney. Can't you take a bad kidney out and that person actually survive on 1 kidney?
So it's not that one kidney is bad at affecting the other kidney. It's just that the kidney function overall is not enough for that person to sustain enough function. But also, in fact, actually, the medical students often ask this: "Well, why don't you put the kidney where the other ones are?" Because it would be a huge operation. If everyone feels, can you feel the bottom of your rib cage just at the bottom? The kidneys are actually tucked under the rib cage. So to get to the kidney, to take that out and put another one in, you might even need to break a rib. And I will tell you that in the olden days, when people used to donate kidneys, in fact, it was extremely brave people that used to donate kidneys when they first started doing them. They would often actually break the last rib. Later, they didn't have to do that, but it was with a huge scar on the back. Fortunately, who knows how they donate kidneys nowadays? It's by laparoscopic surgery. It's by laparoscopic, so it's keyhole surgery. So you wouldn't even know that they've had anything done. But then to take that kidney out and then start working to put the other one and manipulating will be so difficult, and then there's a lot more you can damage rather than just popping it here. And people are fine, they can get on with one kidney. A question?
You're a lupus patient and you wanted to donate a kidney, you have a kidney involvement, can you do that?
And you wanted to donate a kidney. If you're a lupus patient and you want to donate a kidney.
We have a kidney involvement. Let's say one of your kids needed
A kidney.
Yeah. If you had no involvement, but you had lupus, could you donate?
The problem is that although you might not have involvement now, you might have involvement later. Because remember we talked about that some people present with lupus and it's only years later that they get the kidney involvement. And remember, it's like, yes, we do like to do kidney transplants, but one of the things that we're taught as physicians is that the first duty is to do no harm. So the people that we take kidneys from, that we agree, they go through a whole process. They're examined, they have multiple tests, making sure that they're the fittest of the fit, and that if they do to give a kidney, that they won't end up with kidney disease or on dialysis themselves or asking for a transplant, because they can't get it back once they've given it. Is that fair? And then, yes. That lady, and then,
And also,
yeah.
I was doing
Yes.
I just had a question about you said about if the kidney disease happens acutely, that sometimes, well, often
Can
they can
reverse.
recover.
Yeah.
I've been told already that mine aren't going to recover, but then in the so I'm in the process of transplant. But then in the last month or so, they've kind of improved enough that my urine output is improved a lot. And like, what are your thoughts? I know obviously you can't say, you don't know, you can't predict these things, but like, have you? Because I was told that if they were to come back, they would come back within 3 months, and obviously this has been over 3 months. But have
Usually.
you seen any other scenarios or?
Usually. So I'm going to quickly say something. 2 things. Usually they do come back in 3 months. Sometimes it can be longer. But from the sounds of things, and also bearing in mind the treatment you said you've had previously, it sounds like you had pretty severe disease anyway. So even if there was some recovery, I don't think you'd get back to that normal kidney or even the stage 1, 2, 3, as it were. But then the other thing to bear in mind is that with hemodialysis, people tend to pass less urine. And the reason being is that when they do the hemodialysis, did you notice how they pull the fluid off? Like, oh, let's take 2 litres off today. Let's take 3 litres off today. But it's not the same with peritoneal dialysis. It's a slower, gentler treatment. And therefore, people often pass urine with peritoneal dialysis. Does that make sense?
Yeah.
So it's not necessarily a sign, because it's more the quality of the urine.
Yeah.
Is it removing the toxin?
Yeah, but then if my creatine levels came down or something as well, would that be a...
So there's a special test that they can do, and maybe they've done it. It's a peritoneal and adequacy
PET,
test.
yeah.
Have they done it for you?
Yeah, they did the first one, a couple of weeks ago.
Okay. So there are ways of monitoring that.
Yeah.
And also because you see them frequently.
Yeah, they'll let me know it.
Yes.
I'll just
But you're
sit tight
fortunate
now.
you've got a transplant.
Yeah,
It
I've got
sounds
a
like it's a life
exactly.
dose.
So that's very important.
So let's just bring the meeting to a close for the morning session. Thanks very much, Joyce. I'm really grateful that you spent the time answering a lot of questions.